Our first speaker is Dr. Janani Narumanchi. Dr. Janani is an award-winning pediatrician with 17 years of experience. She brings her transformative leadership experience and creative thinking in patient care, streamlining processes, telemedicine, and clinical operations to her current role. While she enjoys practicing medicine, Janani found her missing spark when she dabbed into the potential of utilizing AI in improving healthcare delivery. You can count on her to throw a perfect first pitch at a baseball game or business pitch to her investors. Let's welcome Dr. Janani Narumanchi.
Thank you for that kind introduction. Hello, everyone. Good evening from Memphis. My name is Janani Narumanchi, and our company is called Aspirations LLC. It's a West Virginia-based e-health company. So imagine you don't feel well, and you call your doctor for an appointment, and you can get one because your doctor's schedule is full. How did that make you feel? Your doctor, on the other end, is sitting in her office waiting to see patients, and the patient does not show up. You are not happy because your health was impacted by whether another person showed up for their appointment or not. Your physician or provider is not happy because the patient who needed access to them could not get in, and the administrators are breathing down their neck because they want them to see as many patients as possible in any given day. Getting healthcare at the time the patient needs is one of the frustrating problems that the administrators deal with, and hence they are also interested in solution for that. Even though the reason for frustration is different for each participant of this healthcare triad, it negatively impacts everyone involved. Patient reminders for their appointment is not enough because several factors are contributing towards the no-shows. Healthcare systems have used reminder phone calls, text messages offering urgent or same-day appointments, and many, many more other options. All these labor-intensive manual measures can bridge the gap to some extent, but they surely fail to tackle this problem head-on in the long run. The medical scheduling software market was valued at $234 million in 2018 and is expected to grow at 12.7 compound annual growth rate during 2021 to 2026. Whether a patient shows up or not, the practice still has to pay wages and cover expenses. No-show impacts healthcare delivery to those in need as it decreases the patient accessibility, delivery of quality of care, and results in revenue loss for clinics and institutions. Aspirations, our company, presents simplified scheduling using artificial intelligence. As you all know, artificial intelligence is one of the most game-changing functionalities in IT space right now. The use of AI in this context deals with managing a vast matrix of seemingly disparate sets of data that result in no-shows. Our model connects the dot to yield an actionable tool to analyze the data and suggest a path forward. The advantage of AI is that the tool is heuristic and can learn as it goes along, bolstered by additional data at various levels. With our predictive model, we aim to resolve the accessibility challenge for the patients, delivery of quality of care for the providers, and the economic and logistical challenges for the administrators. Smart tool scheduling can ensure the patients are scheduled with the appropriate provider based on their needs and condition. By optimizing the match between the patient and the providers, it contributes to better healthcare outcome and patient care. Our software system uses historical patient demographic data generated over the past 5 years and then gives a no-show prediction probability. Research shows that the sooner that the patient gets an appointment, the greater the likelihood of them showing up for the appointment. Our algorithm allows them to schedule appointments sooner than traditional booking by opening more potential dates and times. For example, 6 to 7 options of strategic appointment options instead of 3 to 4 options by traditional booking. Patients who have reasons other than transportation issue, who prefer appointments at a certain time of the day, can be offered appointments in their preferred slots rather than blindly offering them any appointment any time of the day. For those who are very well informed or have had communication prior to getting to their appointments and need a quicker appointment, they will benefit from strategic double booking. Imagine the benefit of closer appointment or telehealth option for follow-up post-hospital discharge to minimize the likelihood of readmission due to loss of follow-up. Our model interfaces with existing medical record and scheduling databases and generates a probability scoring factor for use by the medical offices to predict no-show rates. The user interface then offers the schedulers options on where to schedule and what type of visit to offer. For example, in-person visit versus telemedicine visit. Our innovative scheduling tool can bring numerous value-added gains and benefits. For instance, it enhances appointment efficiency by automating and optimizing the process of booking, updating, and managing patient appointments. The efficiency gain allows healthcare provider to allocate their resources more effectively, reduce wait time, decrease the no-shows, decrease the provider idle time, and improve overall efficiency. This leads to cost saving and maximizing the value of their resources. Another benefit is improved accuracy by decreasing the conflicts and errors. Our dynamic model adapts and improves accuracy using patient data and with faster learning and quicker turnaround time to implement. Initial testing of our algorithm resulted in no-show prediction rate of 90% as compared to other scheduling software applications with a prediction of 68% prediction rate. Furthermore, currently available solutions are not dynamically adaptive. They rely on physicians for protocols, which have increased variability and cannot be implemented at a system level. Our patient-centric model considers patient preferences and generates data and analytics that can be utilized for future scheduling decisions, identifies the areas of improvement, and leads to data-driven decision-making. Our model can scale to accommodating growing demands, ensuring that the patients are scheduled appropriately without compromising efficiency or accuracy. According to a recent report by Markets and Markets, artificial intelligence in healthcare market is projected to grow to $67.4 billion by 2027, with a CAGR of 46.2% from 2021 to 2027. According to a study by SCI Solutions, the patient no-shows and missed appointment cost the US healthcare system close to $150 billion in missed in a year, and about $200 per physician for the unused time slot. Putting it another way, a 10 provider practice will lose about $850,000 in revenue annually because of missed appointments. We believe, based on the knowledge gained from our customer interviews, that the administrators of private clinics, large institutions, and veterinary and dental clinics will be interested in our technology, since it can significantly boost patient and provider satisfaction by optimizing patient care and revenue generation. We plan to initially work on the health outcomes of general population and later spread the wings into the animal world. Our business model is to generate revenue by utilizing fixed fee, which is a stable source of revenue at the time of installation, and then a scalable source based on the size of the facility and percentage of the no-shows. We want to simplify the payment process by eliminating the third-party involvement and do direct billing. Our software team is ready to build the algorithm for commercial use that will have interoperability algorithm so that it can be easily deployed into different EMR scheduling systems. Once the software is deployed, we will utilize the services of our beta testers to validate the model, integrating it into different EMRs as a seamless scheduling workflow. In addition to my husband and I, Dr. Yanamala and Dr. Hathaway are part of our team as our technical leads. I'll be happy to answer any questions you might have.
Thank you, Janani. That was a great presentation. I think that this is an excellent idea. I had a couple questions, and in the audience, please feel free to join in for any questions. But the first question I had was, have you already, you've created the software, but you haven't actually used it in private practices yet, correct?
We tested it when we were making the model, and right at that time when we had the COVID pandemic. So we didn't deploy it, but we utilized the data to see if our prediction still was correct. But we have not deployed it in real life practices. No.
Okay.
We need the software for the commercial build to use that to deploy into any practice at this point.
Okay. Definitely, you should take a look into, since I work with Epic directly, you should take a look, in terms of having them review the application, because, we look at that, and that would be amazing if we could use that within Epic itself.
Actually the program was developed using the data set from Epic scheduling. I was in a system that used Epic at that time, so.
Oh, okay, perfect. And then my second question was, have you been able, like using this AI, have you been able to identify social determinants of health and how, that may affect the scheduling?
So when we developed this, I was at West Virginia University, and yes, we did. They might not have a diversity of population that Memphis has, but there is economic diversity of population there, and we did use the data to get some information for that type of social determinants. However, our plan is moving forward. We have a couple of groups in Memphis that we have talked to who are willing to be our playground, if I may use that term, once we are ready to put it in real practice.
Okay, that would be great, because I know like that's the hot topic now with social determinants of health. Because when I see patients who come to the hospital, you can do everything for them, but if they don't have transportation, access to food, it doesn't matter. We can give them the best medical care.
And that's one of the things that we learned. Initially, we thought it was just for the in-person visits, because we developed this around the time of, it was around 2019 when pandemic had not hit us yet. But fortunately or unfortunately, we had to switch to telehealth when we were in West Virginia because of the pandemic. And we did check the validation of the algorithm, and it does work for telehealth visits as well. So that's one of the features of this algorithm, where we can offer telehealth versus where we should be offering in-person visits, just because, as you mentioned, in some cases, transportation is a barrier, and offering Ubers to bring the patients to the clinic has not worked, because some practices have even tried that.
I agree. I'm going to open it up to the audience. Does anybody else have any questions?
I'll ask one.
Sure.
So Janani, great idea. And as I said in the intro, I'm a retired orthopedic trauma surgeon. What we often did, not a very elegant solution, but on some of our high revenue appointments like physical therapy or MRI scheduling, we would just intentionally overbook by 1/3, which, you know, isn't as elegant as an AI solution. So I applaud you for trying to figure that out for us. But my real question is, and I know you haven't been in the clinic yet, but probably the only thing the patients hate more than either missing or canceling appointment is having to wait forever once they show up. And I think it would be interesting because obviously clinics have gotten used to, for the most part, operating with a no-show rate that, although costs them revenue, does give them time. So it'd be interesting to see if you can collect data on wait times and or patient satisfaction with the system once it's up and running or beta testing, because these clinics now may have more patients back to back than they can actually handle.
Thank you for that feedback. We did initially think of strategic double booking as the only option, but as we learned more, you're absolutely right. If you double book beyond a certain number, it actually clogs the clinic, and that's not an ideal solution either. So hence, we are now utilizing telehealth as an option, as well as some people. For example, you and I, if we work in the daytime, we might prefer either a very early morning appointment or later in the day appointment. So if I should call for an appointment, this would lead for the scheduler to only offer me those times rather than trying to look for another times, just to make it easy and quicker. And as you know, a lot of EMR systems are now also allowing self-scheduling. So that also helps. And when the self-scheduling options come up, it gives you options that might work with your scheduling rather than wasting your time and making you more frustrated with self-scheduling. I see another question. Miss Dr. Wiesen. Did I say your name right? I'm sorry.
Oh, sorry, you flatter me. Not Dr. Wesson. Sorry, just Mark. Thank you for your presentation, Dr. Narumanchi. I had a question. As someone that worked in an outpatient clinic for 6 years, saw a lot of machinations in the scheduling, and a lot of tricks and things that worked and didn't. Can you explain to me one more time how the software goes from what amounts to a risk score to actionable scheduling options? Again, can you explain that for me?
I will try. So I don't know if you have ever seen Epic. We at West Virginia University, we had Epic. So it actually already gave a no-show rate whenever the schedule comes up that this patient has no-show rate, but it also has information. There might be a no-show rate for a specialty visit versus a primary care visit. They don't differentiate that. They just give you one score.
Okay.
What we are saying is, okay, we know the no-show rate. Then what's the next step? So one of the things is that right now when a patient calls, the call center people are supposed to answer that phone call and schedule an appointment within the 5 minutes. They can see the no-show rate right in front of their face, but they have no authority to do anything because they have no solution that they can implement themselves. The managers or the administrators have to tell them what to do. And that's where protocols come. Sometimes they act as barriers, sometimes they facilitate moving the scheduling process in the right direction.
Right, yeah, I've dealt with call centers. I've dealt with these types of venues before, yes.
So what we are saying is when this comes, say a patient calls, so say you call for an appointment, it brings up and it tells me what is your history, and this is all happening in real time. Our AI model will tell me what was your history of which appointments you, if ever you no-showed an appointment, which appointments were they, what time of the day. If it was we had 10 various factors that contributed in building this algorithm. So it includes the weather conditions, the transportation, the zip code, the time of the day, and all of that. Using all that data, it gives me a predicted probability score, giving me a prediction of what is your probability of adhering to an appointment if I give you at this time. And based on that. And then based on that, so even that information, it's great, I get a probability score. But the next step is, how does the user who might be a high school graduate from a call center utilize this? So the next step is it then connects that probability and gives the user these options like X, Y, and Z option instead of opening the whole schedule. So if you saw in my, may I share my screen one more time?
So it gives the scheduler,
Yes.
it gives the scheduler kind of a shortened, truncated view with just more direct, appropriate options. That okay, good.
Yeah,
nice.
I can show you that one slide if.
And it's working in the background, correct? So the patient doesn't see it, and then
No.
the scheduler doesn't see it.
It's
Okay.
only the scheduler who sees it. I'm sorry.
Mm-hmm.
Okay.
So this is what the user interface for the scheduler would look like. We are trying to simplify for the scheduler because whatever the probability doesn't matter for the scheduler. They just need an answer because they have to still.
That's my point, right? It's how do we bridge that and go from intel to action, right?
Yes.
Where the pothole is in the bridge so often.
So then it works through, and we have a whole, algorithm for that as well. But what it shows is offer this appointment because this appointment might give you a 10% no-show, whereas this appointment might give you 14%. So
appointment
this is
types.
Yes.
Beautiful.
No, this is excellent. And then also it would be great.
I-
You can also use this on the inpatient setting too, for patients who were getting ready to discharge, who is more likely to be a no-show.
Oh yeah.
So
I discharge prediction. Oh boy. Yeah.
I had the luxury of the data because I was a medical director for all pediatric clinics, specialty and primary care in West Virginia. So all of this was built in pediatric setting, but we hypothesized that we can actually implement it for imaging studies, for any outpatient clinic, surgical specialties, even inpatient once we get to it. And I did an ICOR course with NSF, and in a customer interview, we realized that the dental clinics and veterinarians also have similar problems. So it was surprising to us that they also would like something like this for their scheduling software. However, we are still trying to generalize it from pediatrics to general population. And then, as you mentioned, West Virginia has a different set of social determinants and Memphis has a different one.
Yeah.
So we have to, that's
I'm from Arkansas, by the way.
Okay. So, hi neighbor.
Yeah.
So based on that, that's where the beta testing will give us a lot of information, and we have to then fine tune the model. And once we have that, then that's one other lesson we learned. Initially, I came from a big institution, West Virginia University, and we were talking with Epic there, and we learned that things move slowly when you have a bigger institution, but when you have a smaller institution like a private practice, decisions can be made in real time, and we can fine tune as we go. So that's our plan. I have a couple of colleagues and friends who own private practices, and they're interested in allowing us to try this in their private practice, fine tune it, and then the next step is to take it to bigger institutions.
That's great. That's great. Thanks so much.
Thank you.
Okay, great. Thank you, Dr. Narumanchi. Okay, great.